diabetes and women. So the next slide, please. The flow would be on the statistical differences. How is diabetes different in women? The risk factor. And we'll focus a bit in details about gestational diabetes, menopause, and PCOS, the complication, and last but not least, pharmacotherapy. Next. So, if we look at the data, basically, we all are aware of the fact that diabetes indeed affects women differently than of men. And if we have a look at the data, it's indeed alarming because 215 million people, women, are affected with diabetes in the world. And this is actually highlighting that a significant proportion of the global burden of diabetes is by women patients. And unfortunately, the mortality risk is twice than that of men, highlighting the disproportionate impact of diabetes on women's health. And 50% of these cases might be undiagnosed, probably due to lack of access to proper healthcare as well as gender bias, etc. Next. So, how diabetes differs for men and women? Women with diabetes have it worse on average than men with diabetes, while men with diabetes live 7.5 years less on average than those who don't have diabetes. Women, the difference is even greater, it's 8.2 years. The risk of heart disease is 6 times higher for women with diabetes than those without. And also, type 2 diabetes is more prevalent in women than men, making prevention and early detection particularly important. Next. So now coming to the gender disparities. So first of all, the reproductive health, like sir was mentioning, that majority of the women go through periods of puberty, childbirth, menopause, perimenopause. Some of them have PCOS throughout their entire life, which a man is obviously not going to experience. And this is the time where there are lots of hormonal perturbations. And because of these hormonal changes, it has its effects on insulin resistance, insulin sensitivity, glucose control, etc. So the management of diabetes is actually coming through across as a varying landscape, and that makes it more challenging. Secondly, social factors. For instance, women, they are seen as caregivers, but at times, so it happens, just like my previous speaker was mentioning, that they take the child to the school, to the doctor, but they don't bother about themselves. So sometimes the responsibility of taking care of the family is so overwhelming that they end up ignoring their own health, and that is how things become even worse. Last but not least is bias. In our country, even in many areas, it is still seen that a woman's health is often neglected. It's not given importance to, those issues are not highlighted, and sometimes patients have subtle symptoms which even are overlooked. So these are the disparities. Next, beyond this, we also have some biological factors like the body composition and fat distribution. In women, we have predominant fat, and this fat has got relation to glucose uptake, storage, as well as insulin resistance. Secondly, immune response. This again is different in case of women as compared to men. If we see that the cardiovascular risk factors or the CV risk mortality is much higher in women, and that is because the degree of atherosclerosis inflammation is different. Also, in women, sometimes the symptoms may be a little silent or atypical features which might be ignored. Coming to the hormonal influences, in particular, estrogen is actually having a protective role. So that is why postmenopausal women, when the estrogen levels go down, they are at increased risk of developing CV disease. Progesterone, on the other hand, actually worsens insulin resistance. That's why in many studies we might find that in the luteal phase, the requirement of insulin might go up or the sugar levels might be out of control. Testosterone has got mixed reviews, so we need more data for better elaboration. Next. So here I've just kept summarized the factors which might either be differing or might be contributing. So menstrual cycle. Now here again we have mixed information because some studies suggest that there is a variation in the glucose levels throughout the menstrual cycle, especially in the luteal phase, where due to the effect of progesterone it might be going high, the sugar levels might be uncontrolled. Secondly is the CV risk, which we'll be discussing in detail. Pregnancy, it's very important that the HbA1c levels should be kept in control. They should be less than 6.5, and pre-pregnancy pre-conceptional counseling is to be done to every patient so that they can have a better childbirth outcome. Bone health, this is again an area which needs to be attended to because we have varying data. For instance, in patients of type 1 diabetes, the bone mineral density is lesser, whereas in patients of type 2 diabetes, the bone mineral density can actually be normal. So these are areas, but even though it is normal, whether it is a patient of type 1 or type 2, they are susceptible to fractures, and the microarchitecture is actually not that good. Genetic predisposition. So if there's a female who's having diabetes, there's a greater chance that the female relative of her would be developing diabetes. Prior risk of gestational diabetes mellitus. This again imparts a greater risk. PCOS will be, and menopause, which we'll be dealing in details. Next. So, first we'll be discussing about GDM, the prevalence of which, if we see in 2019, as per IDF, 1 in 6 live births worldwide were complicated by gestational diabetes, and 90% of cases were in low and middle income countries. Next. Coming to the Indian data, so a recent study by the DIPSI has shown the prevalence of gestational diabetes in India was about 17.8% in urban and 13.8% in semi-urban and 9.9% in rural areas. And even prevalence as high as 35% from Punjab and 41% from Lucknow have been reported. Next. So, in very brief, what are the complications? Patients of gestational diabetes, short term complications would be preeclampsia, gestational hypertension, hydramnios, UTI, vaginal infections, cesarean delivery, perineal tears, PPH. Long term complications would be recurrence of gestational diabetes, development of type 2 diabetes, hypertension, ischemic heart disease, dyslipidemia, NFLD. Next. We also have some complications which are perinatal, because the sugars, the maternal circulating glucose, enters the placenta and enters the fetus. So, what happens is that there is an increase in the fetal circulating insulin as well as IGF-1 levels. Because of that, there can be macrosmia. Because of macrosmia, there might be premature delivery, there might be shoulder dystocia leading to brachial plexus injury. There might be hypoxia leading to stillbirth. There might even be cardiomyopathy. At the same time, because of these increased IGF-1 levels, there can be neonatal hypoglycemia. There can also be decreased lung surfactant synthesis and function. So, gestational diabetes is very specific to women, and it can lead to not only maternal complications, fetal as well as perinatal complications. So, this has to be addressed properly. Next. So now moving on to menopause. So what really happens in menopause is that there is a substantial decline in estrogen production. There is also a decline in androgen production, but the androgen production decline is at a lower rate. So that is why what really happens is it leads to a situation of relative androgen excess. And because of these hormonal alterations, the central adipose tissue deposition increases, insulin resistance increases, and there is a decrease in lean body mass. That is why the incidence of diabetes dramatically increases when women come to the postmenopausal period. Next. So here, if you look at this diagram, post menopause, the estrogen levels are going down. There is a relative androgen excess. Because of this, pro-inflammatory cytokines are increased visfatin, whereas adiponectin, which is a good entity that is released from the fat cells, is reduced. Free fatty acids are increased. All of this put together, insulin resistance seeps in, leading to hyperglycemia, dyslipidemia, and hypertension. Next. So I've already discussed the metabolic changes. So basically, what happens is the SHBG, that is the sex hormone binding globulin, that reduces. So there is again a situation of relative androgen excess. This is again due to insulin resistance. There is chronic inflammation. There is reduced insulin signaling through the reduced activation of the estrogen receptor alpha, and there is increase in production of free fatty acids. So all of these put together lead to the variation of sugar levels post menopause. Next. So I'll just be very brief about this slide. Basically, that if any patient is having menopause early or premature ovarian insufficiency, then the risk of subsequent type 2 diabetes also increases. That is, a shorter reproductive lifespan is associated with increase in risk of incident type 2 diabetes, probably because of the protective effect of estrogen, which is gone. Next. Next. So now we'll just have a word regarding the interplay between PCOS phenotype and metabolic syndrome. So in case of women, those who are having polycystic ovarian disease, metabolic syndrome, insulin resistance, obesity. So all of these actually belong to the common spectrum of metabolic metabolic syndrome, and they are all acting as basic substrates, and each is linked to the other. So there is insulin resistance in a patient of obesity, which leads to PCOS in a female, because of and that leads to hyperandrogenism and ovulation, irregular menstrual cycle. So management of weight as well as disciplined lifestyle is equally important. Like my previous speakers were even mentioning, that it's very important that everything healthy should be followed. The diet should be healthy, proper physical activities to be done, sleep is equally important, no smoking, cutting down on alcohol, taking mostly proper nutrients, healthy vegetables, etc. is to be encouraged. Next. So coming to the complications, special issues are, next slide please. Yeah, so women are at greater risk of developing coronary heart disease, and they have decreased life expectancy. Next. So, in a large cohort referred for coronary disease, diabetic women had the highest mortality rates. Next. So, this is next slide, please. So, this is just a graph I've kept according to the Framingham Heart Study 30-year follow up, and it was shown that the CV events were greater in women than compared to men. Next. So this is again another slide which I've kept, which is showing an association between type 2 diabetes mellitus and women cancer, and probably the changes in the bioavailable ovarian steroid hormone are actually responsible for causing this cancer initiation. Next. We also have psychological issues with diabetes. Patients have increased levels of anxiety, diabetes related distress, guilt, etc. Next. So I just have two or three more slides. I'll quickly go through. Coming to the sexual health, which is often ignored, patients complain of vaginal dryness. That is, female patients of diabetes have about vaginal dryness in 30% of the cases. They have recurrent infections. There's greater chance of developing UTIs and genital mycotic infections. Sometimes there is decreased libido, which we usually do not attend in our regular clinics, and communication barriers because they don't really express themselves in majority of the cases. Next. So, coming to the anti-diabetic agents, I won't go through these slides. I'll just briefly summarize. So, most of the anti-diabetic agents have a similar adverse event profile in terms of gender, but because the SGLT2 inhibitors act with a different mode of action, they need special consideration because they're associated with genital mycotic infections. Next. So, in majority of the cases, if the patients are taught that they need to maintain the hygiene, drink plenty of water, keep themselves clean. So, in these situations, if we treat them with an antifungal, and maybe after 6 months or so, if things are fine, we can also reinitiate it. That is one thing that has to be kept in mind. Next. 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 Okay, so recommendations. This is my last slide to improve the diabetes care. Education, very important. Nutritional education. Importance of physical activity should be emphasized. During pregnancy, excess weight gain is to be avoided. Next. Postpartum follow-up is important, and any policies that empower adolescent girls and young women to take control of their metabolic management must be encouraged. Now, please show my last slide. So I have just kept this slide to highlight the women celebrities who are suffering from diabetes. So even if a woman is having diabetes, it should not be taken as a setback, and she can pursue her dreams provided right treatment, right management approach, and everything is followed. Thank you very much for your patient hearing.